Welcome. Thank you. What I wanted to talk to y'all this morning about is a procedure called uterine fibroid embolization, or otherwise known as uterine artery embolization, which is an alternative to hysterectomy in ladies that have uterine fibroids. This is just a little MRI picture of a uterus, and we'll see several more of those as we go along here. I'm with a group called Radiology Associates. We're an independent radiology group, but the vast majority of our work is done at Our Lady of the Lake Hospital. So what is a fibroid? It's the most common tumor of the pelvis. It's otherwise known as a leiomyoma or a myoma or a fibromyoma. It's a benign tumor. It is not cancerous, nor is there any risk that it will become a cancer. It can be anywhere from the size of a grape to as large as a cantaloupe or a softball. There's a wide variety in sizes. Most fibroids don't cause any symptoms. Most ladies that have fibroids are walking around and don't even know that they have them. What types of fibroids are there, or where can they be located? The first is called, we call subserosal, and what that is it's on the outer part of the uterus, just beneath the outer lining of the uterus. These types of fibroids are unlikely to affect your menstrual cycle. They can be a source of pelvic pain or back pain, and they can grow on a stalk, and that's called pedunculated. And if you can see here, this is an example of a pedunculated fibroid. This is the top of the uterus, and you can see here it's just kind of hanging off on this little stalk here. And we'll talk a little later about why it's important to know that. Second type of fibroid is called intramural. These are fibroids that are in the wall of the uterus themselves, or itself. This is an intramural fibroid here. This is a subserosal fibroid, and this is an intramural fibroid on the top of the uterus. This is the most common type of fibroid. It can definitely cause pain and heavy bleeding, and it can cause symptoms of pressure, and it can definitely cause the uterus to really be quite large. And the last type of fibroid is submucosal, and these are fibroids that develop just under the uterine lining or the endometrial lining. These are the least common type of fibroid. However, we definitely do see them, not infrequently. However, these are the most likely type of fibroid to be symptomatic. So in my practice, where I typically see patients that are having symptoms related to their fibroids, I see these quite commonly. These fibroids, the submucosal fibroids, can definitely cause heavy and prolonged periods, and they can be associated with infertility. And with these types of fibroids, it's particularly important to know if they're pedunculated or on a stalk. And we'll talk about why shortly. So who gets fibroids? About 20% of ladies in their 20s get fibroids. Same, about 30% when you're in your 30s, on up to about 40% of ladies when they're in their 40s. There definitely is a genetic predisposition, and there is a well-documented increase in your risk if you're African American. We see these in all ladies, all Caucasian, Asian, but there's a higher incidence in ladies that are African American. There's definitely also a familial tendency as well. So if you have a sister or a mother, say, that have fibroids, you definitely are at increased risk. So again, it's important to know, most ladies that have fibroids don't have any symptoms. And if you don't have any symptoms, there's really no point in doing anything about your fibroids. But again, in my practice, I obviously see the ladies that do have symptoms related to their fibroids. So what kind of symptoms are we talking about? Most commonly, we see heavy and prolonged periods, periods that are unpredictable. They come at various times during the month. Some ladies bleed so heavily that they become anemic, and I've definitely seen patients that have even needed a transfusion because they're so anemic. Then probably a close second is pelvic pain. Almost all ladies have a little bit of pain associated with their cycle, but the ladies that we see in our practice typically have some fairly severe pain. Urinary frequency. This right here is an MRI of the pelvis taken from the side. And the reason I show you this big dark blob here is a very enlarged uterus that contains fibroids. I'm sorry, it doesn't project very well, so you can't see it all that well. But the reason I show it to you, this little white spot here is the bladder. And you can see this big uterus is compressing on the bladder. And you can imagine why that would cause a lot of problems needing to go to the bathroom quite often. It's the equivalent of being pregnant. You know, ladies that, if you've had children towards the end of your pregnancy, I'm sure you've had a lot of problems with needing to go to the bathroom quite often. And in the other extreme, it can actually cause problems with constipation, because if you can see here, this is actually your rectum. So sometimes the uterus can actually impress upon the rectum and cause problems on the other end, so to speak. It can definitely cause an enlarged abdomen, and it can cause infertility. The fibroids can dramatically increase in size during pregnancy, and that's usually related to some hormonal changes. On the flip side, in ladies that have entered into menopause, typically the symptoms related to fibroids improve. Typically the fibroids get smaller, and if they are having heavy bleeding, obviously during menopause, all bleeding typically stops. Sometimes it can kind of continue on a little bit, but typically the symptoms improve. The big question is how soon and when, because I have seen patients in my practice that are beginning to undergo menopause, yet are still having some fairly significant symptoms. And a lady I actually treated this month, she was in the early stages of menopause, but we still chose to treat her because she was just so desperate to have some sort of relief that she did not want to wait, you know, potentially months to years for menopause to kick in and relieve those symptoms. So how are they diagnosed? Typically, you go to your OBGYN, he or she does their typical exam. Oftentimes they'll do an ultrasound in the office. We see that very commonly. MRI. Once a patient comes to me and we are considering the uterine fibroid embolization procedure, we always do an MRI on every patient. And it's very important. The reason we do that, typically, yes, we know you have fibroids at this point, but the MRI shows the fibroids and the uterine anatomy in exquisite detail. And it answers a couple of very important questions, the most important of which is, do you have one of those fibroids that are on the inside part of the uterus, and is it on a little stalk? And that's very important to know, because it can, if we were to choose to treat you, and when you did have that type of fibroid, that fibroid can die off and actually fall off inside the uterus and result in a really bad infection. So it's very important for us to know that beforehand, because I have had patients that had that type of fibroid. We don't see it that often, but on occasion we do, and I've had patients, I'll typically in that case recommend the patient go back to their gynecologist. The gynecologist can usually remove that particular type of fibroid just with a little scope. My own wife actually had that procedure, and assuming you have other fibroids, you can come back and we can go ahead with the embolization procedure safely. And there's some other modalities that, like CAT scan and sonohysterography, which involves instilling some fluid in the uterus, and also a scope that can also diagnose the fibroids. So what treatments are available for ladies that have fibroids and are having some symptoms? And what we're here to talk about today actually is a good alternative to hysterectomy, which is usually the #1 procedure that's recommended for fibroids. So again, we do the MRI. This right here is a picture kind of taken from the side, and this is a picture kind of looking from your feet up towards the head. And I'm sorry it doesn't project very well, but this is a very enlarged uterus that contains several fibroids, and this is that same uterus looking from the side. This is a picture of our angiography suite where we perform the procedure. Little table here. This is our X-ray equipment. So what does the procedure involve? You come into the angiography suite on a routine basis, whatever's convenient for you. We give you conscious sedation. Not an open surgery. It just involves a little numbing medicine in the groin, which feels like a bee sting. You're already sedated at this point. We insert a little tube into the artery in the groin. Again, there's no open incision. And through that tube, we can insert an even smaller tube into the left and the right uterine artery. And those are the two arteries that provide blood supply to the uterus. And through those little small catheters in the uterine artery, we'll inject some very tiny particles. And we have a picture of those coming up. And we basically block off the blood supply to the uterus and all the fibroids, and essentially starve the fibroids of oxygen in their blood supply. We do a pelvic angiogram. We'll show you some pictures of that shortly. And again, we're able to treat the entire uterus and all of the fibroids, all through that small little nick in the groin. These are a couple pictures here. This is a picture, two pictures from an angiogram, just to orient you here. These are your hip bones here. These are your hip joints right here. And all these little black lines you see, those are the arteries in your pelvis. And if you can kind of make out here this circle, that's a uterus containing a bunch of fibroids. And these are pictures once we've gotten a smaller catheter into the uterine artery, and you can see this dense blush here. This is the left side of the uterus. Once we've injected contrast dye into the left uterine artery, and this is an injection of the other side, of the right side of the uterus. This is another angiogram. These are just the arteries in your pelvis. This is your aorta. And again, when we're doing all this, you don't feel anything. There's no pain. You may feel a little warmth in your pelvis, but there's no pain at all during the procedure. And this is two images. The one here shows, again, contrast dye injected through that right uterine artery, and you can see here the uterus. And this is what it looks like once we've injected those particles. You can see here that there's no more blood supply to the uterus. That's exactly what we want to see after we've injected the particles. And again, this is just a little picture of the particles that we used. These particles have been specifically designed for this specific procedure. And there's been lots and lots of research done as to what particles are best. And there's been conclusive evidence that the ones that we use are superior to everything else out on the market. So what can we expect after the procedure? Again, we use a little device to close. There's a small hole in the artery that we make, and we use a device to close that. And the reason we do that, most times when you have an angiogram, you have to lay flat for 6 hours, which is not very appealing to most people. The device that we use to close the hole enables us to allow our patients to get up and moving around within 2 hours. So it's a lot more favorable. I admit all of the patients overnight for what we call a 23-hour admission. It typically does not last that long, but we typically admit you overnight predominantly for pain control. We use a PCA pump, which is a pump that you can control. It will not let you give yourself too much medication, but we found it's really effective in relieving any pain. And when I say pain, typically patients will have cramping in their pelvis above their baseline. And that cramping usually is the worst for the first kind of 8 to 12 hours, and it usually steadily improves after that. It's not uncommon at all to get some nausea, and usually that's related to the medicines that we're giving you. But we're better suited to control all that while you're in the hospital, because we can give you some IV medicines to combat against the nausea as well. There are some guys in other parts of the country that are sending patients home the same day. I have a protocol for that, but quite honestly, I haven't tried it yet, because I just feel like we can so much better control any potential issues while you're in the hospital. So I just hate to send a patient home and have her end up in the emergency room at 2 o'clock in the morning because she's having too much pain or having some nausea. That's stuff we can easily control while you're in the hospital. We have you go home first thing in the morning. We follow up over the phone for about a week. We usually will do a follow-up MRI in a month, and then another one in 6 months, and obviously see you back and see how you're doing at that point. And we're going to go over some of the results shortly. There is what's called post-embolization syndrome. It's not an illness or a sickness. What it is just It describes some symptoms that are pretty common that patients will incur after the procedure. It's not uncommon at all to have a very low-grade fever, a little pelvic cramping, and nausea. That's what we see most often. And again, we will send you home with pain medicines and nausea medicines. And in our experience, patients do really well in terms of controlling their pain and nausea just with what we send them home. We'll also send you home on a week's worth of antibiotics to combat against any infection. What's the recovery? Usually it's about a week. Some ladies need a few fewer days than a week. Some ladies need a few more. But a good rule of thumb is about a week. And that compares very favorably with hysterectomy, which typically is about 4 to 6 weeks of a recovery. And only the fibroids are affected. The uterus has a very rich collateral supply, blood supply. So even though we block off those 2 uterine arteries, what we find is the normal uterine muscle regains its blood supply almost immediately. It's the fibroids that die off. So in summary, UFE, it's a non-surgical, minimally invasive procedure. It involves a rapid recovery, very few complications. We're going to go over those in just a moment here. And it's a treatment specifically targeting all the fibroids in the uterus. And it does not involve any additional hormone therapy. So let's go over some of the results. I don't want to bore you with too many details, but kind of in the early to mid-90s is when we started doing these, and when they started to collect data. In France was one of the first research papers published. It involved 16 patients, 11 of which had a complete response. And mind you, when they first began doing this procedure, the particles they were using and some of the devices they were using, what we're using now is far superior to what they were using when they first started out with this procedure. This is another study, and I'm going to get to more of a summary slide here in a second. This is kind of a busy slide, but if you look at some of these percentages, this reflects how effective the procedure was. And then the next slide will kind of summarize. So, for bleeding, for heavy bleeding associated with the fibroids, the procedure is 87 to 95% effective in relieving those symptoms. For pelvic pain and cramping associated with the bleeding, it's 85 to 97% effective. Bulk-related symptoms, those are the frequent urination and constipation and generalized bloating feeling. It's 80 to 94% effective. And we found at 3 months, you can expect a 40 to 65% reduction in the size of the fibroid. And I've found at 6 months, this number is even higher. So what are the complications? Fibroid expulsion. 3 to 7% of ladies pass some tissue, some necrotic tissue, and typically that's if a fibroid was submucosal or on the inside part of the uterus. 0 to 5% of ladies have a vaginal discharge. Again, even if you have it, it's typically limited and it does not last very long. The big complication that I don't want to say we worry about, but I'd say it's the one that's most concerning is infection. And that happens 0 to 3% of the time. And how does that manifest? Manifests usually with a high fever and a foul-smelling discharge. We do not see it very often at all. If we do see it, the vast majority of ladies, we just need to keep them on another week's worth of antibiotics, and that takes care of it. I've only seen one lady, and this was about 6 years ago, that had an infection that required her to go to her gynecologist and for them to wash out the uterus, so to speak. It just happens very rarely. Ovarian failure causing menopause. That happens in 1 to 2% of patients. And then things like contrast allergic reactions and complications with the groin we see very, very rarely, about 1% of the time. So what about fertility? Bottom line is there's lots of research going on right now, but there's no official recommendation one way or the other. There are definitely patients that have had the procedure that have gone on to get pregnant. Anecdotally, most ladies I see in my practice either already have children or don't have necessarily have children, but don't necessarily desire fertility or to have any kids going forward. The bottom line is, I've maybe seen 1 or 2 ladies where they said, "Doc, I absolutely have to maintain my ability to have kids." And in those patients, we'd probably say, well, we better hold off on doing the procedure. But again, the vast majority of ladies that I see in my practice, they say, "I'm already done with kids. Let's take care of the uterus." So, but again, there's research ongoing. My guess is they're going to come out with a number that says, okay, this percentage of ladies maintain their ability to have kids. So we just don't know that number yet. So in summary, UFE, it's very effective. It's about 85 to 95% effective in relieving symptoms of bleeding and pelvic cramping and bulk-related symptoms. It's minimally invasive. It involves less than a 24-hour hospital stay and a rapid return to normal activity. You all have some packets, but this is just a slide kind of summarizing some of our contact info, but I think you probably all have that in your packets. And lastly here, Condoleezza Rice, who you all know is the Secretary of State for George Bush. Obviously, she's a lady that really can't afford to be off for 4 to 6 weeks. She was pretty busy. So she had fibroids and had some pretty typical symptoms. And she had a UFE. Unfortunately, I did not do it. It was somebody in D.C., I'm sure, but she had an excellent outcome. So, and she was well publicized. So, that's it. Any questions that I can answer for y'all? Mm-hmm. Good question. Short answer is no. Most ladies, especially when they get into their 30s and 40s, the fibroids that you have are the ones you're going to have forever. We find that really that no new fibroids come back. They can sometimes change in size. They can get a little bigger or smaller. But we find typically that new ones do not develop. Like for instance, in ladies that we do treat with the procedure, I've never seen a lady where, say, we've gone and back and done a follow-up MRI and there's a new fibroid. Right. Well, and that's not uncommon. A lot of ladies just don't know they have them. Right. Right. Well, and that's kind of why we're here, because unfortunately it's been slow in the OBGYN community for them to accept it. We definitely get referrals from a lot of the OBGYNs in town, but it's been slow for them. You know, an OBGYN, you know, they take out uteruses, so that's what they do. So it's definitely, we found some of the younger OBGYNs that are recently trained have definitely bought into it. Some of the older OBGYNs, especially the male ones, don't believe it. But that's okay. But we're trying to educate them and you know, establish open lines of communication. But right. Absolutely. Well, we'd be happy to see you, and really we also need to do a better job of communicating with our family practice docs, because obviously they're kind of the first line, and your NPs that are in that type of scenario, because yeah, they are seeing a lot of these patients, I'm sure. Very good question. We find all insurance carriers, including Medicaid and Medicare, all of them cover this procedure. Yes. Obviously, you know, everybody's policy is a little different in terms of copays and things like that. But bottom line being, we have not had any problems getting coverage for the procedure.
Okay, is there any, I would say, like once you do referral, prior to the referral, are there any workups that you would like to have done prior to coming to see you?
Good question. Short answer is no. Most ladies have had an ultrasound or something, but typically we'll have them come and see us in clinic. That's just it's a real basic clinic visit. We don't even do a pelvic exam or anything like that. It's to talk to you, get a handle on what kind of symptoms you're having. From that point, some ladies already have an ultrasound, some don't, and honestly it doesn't really matter because every single patient we're going to absolutely have to do an MRI on. And so we would, assuming we think you'd be a good candidate, we'd do the MRI, take a real good look at that, and then assuming the patients were, or assuming the fibroids were in a favorable location, assuming your clinical picture fit, I'd typically recommend yes. If there's some other confounding factors or things that didn't add up, I might say, okay, you might ought to go back to your GYN. I might even pick up the phone and call your GYN. You know, there's a variety of ways we handle it. But definitely I encourage open communication between myself, OBGYN, family practice doc, NP, whatever. So, yes, ma'am. Yeah, good question. They're basically kind of like plastic or gelatin type consistency, and no, they don't leak at all. Nor do you feel them. It's not like, you know, 2 months down the line you say, gee, I feel like I have particles in my, you know, they're very small. Their sole purpose is just to block off the blood supply. But no, there's no risk whatsoever of the particles going somewhere that we don't want them to go. Again, on the angiogram, we know exactly where we are when we're treating you, and there's really no risk of the particles harming you. Yeah. I've never heard or seen of a patient having any kind of allergic reaction to them or anything like that. And these particles are specifically designed for this specific procedure, and they've done extensive research comparing them to other. There's lots of different particles on the market to do a variety of type of procedures, but these have been proven to be the best for this. Mm-hmm. It's typically not immediate, but good question. We find basically the fibroids don't develop the collateral, which is good because we want them to die off. But the rest of the uterus, at a minimum, is 30 days because when we do that 30-day MRI, every single patient I've ever treated, that uterine, the normal muscle in the uterus lights up like it normally should. And then what we see is that fibroid that used to light up is black, and it's dying off. So my guess is anecdotally probably a week or so is when those collaterals develop. You can. There's a lot of other things that you can detect with MRI. MRI is usually very good at looking at ovaries. If there's a mass or cysts or anything like that, you can tell if there's abnormal lymph nodes in the pelvis. So yes, it can detect a lot of other problems. Yeah, if there's something that's of concern to me, I remember one lady, her uterus really just did not fit the picture of fibroids. I was concerned that something else, like a cancer, was going on, and I sent that lady back to her OBGYN. I said, I really don't think we should treat this lady. I think we need to look into finding out what's going on with her uterus because I'm concerned something else is going on. So, bottom line, we don't want to do something that is going to harm you or not in your best interest.
Does the number of fibroids that you have impact the results?
Very good question, and we get that a lot. Short answer is no. There's no data out there that says, okay, if you have 6 versus 5, your response rate goes down. No, nor does size. We've treated all comers. I've treated ladies with just 1 or 2 relatively small fibroids. I've treated ladies with gigantic uteruses, just full of fibroids. I will say, if a lady just comes in with an enormous uterus with just huge fibroids, I might say, look, we can still definitely treat you with the caveat that we may not get as good of a response. There's no real hard data that says this size or this number. But I've had 2 ladies especially that I can recall, I couldn't believe how big their uterus was. We still treated them, and they got a good response. But those are ladies that I would say we need to prepare ourselves for failure and maybe looking into surgery down the road if it doesn't work. That's another good question. I've never treated somebody twice, no. And it's, in the literature I've seen, it's just really rare to ever have to need to treat somebody twice. If I haven't really encountered anybody like this, but if I had a lady that I treated and, 6 months down the road, she said, "Doc, I'm just no better, I'm miserable," at that point, I probably wouldn't retreat her. At that point, I would probably send her back to her GYN to consider having a surgery. Luckily, I haven't seen that, but that's probably the way I would approach it. I don't know if I would ever do it twice. I don't know. I don't think there would be much use in that. Nothing. I wouldn't do anything. Just like anything else. As long as it's not something like cancer or something like that, if it's not causing you any problems, I would leave well enough alone. No one really knows. They're just like, any other benign tumor in your body. It's probably a genetic component, is my guess, but bottom line, we don't really know. They just pop up. Right. I'm sure there's just a genetic component that we don't know about, but any other questions? Yes, ma'am. Good question. The recovery, at least, is about a week. It usually takes several months for that fibroid to die off and to kind of shrink up. And what I usually tell ladies, let's say about a month goes by and you have that first cycle. And what I usually say is don't get discouraged if that first cycle is not a lot better, because it's not uncommon to not really get that good of a response after that 30-day period. What I want to see is 2, 3, 4, 5 months down the line. That's when I really want to see some significant improvement. But with that said, we have lots of ladies that, man, their first cycle say, "Doc, I couldn't believe how much lighter it was." So everybody's a little different. Any other questions? Well, we have a patient here, Denise, who's been kind enough to join us. Denise, I treated her for fibroids about 2 years ago, I'd say. And we were fortunate enough to have a really good outcome. So she's been kind enough to come this morning and answer any questions, kind of from a patient standpoint, if you do have any questions for her. So. Thank y'all for coming.